Thank you, panelists. And let me ask Lisa and the final two panelists for this morning to make their way to the front as the staff changes the name cards. And I'm just going to stay out of your way.
You had your hand up a long time. I was advocating for you.
Good morning. My name is Lisa Lehman, and I'm a primary care doctor at Brigham and Women's Hospital. And it's been a tremendous privilege to participate in this conference over the past day and a half. It's been tremendously energizing, and I'm really excited to be able to moderate this discussion that really looks at exemplars on the practice end. And we have two wonderful examples to share with you. And what we're going to do is have each, Kathy and then Tina will each present their work, and then we'll open it up for conversation. I want to, before we go into their presentations, though, I want to maybe set the stage a little bit, and I've talked to them a little bit about this also, and encourage us to be thinking about a couple questions in advance as you hear their presentations. And my hope is that we can have a conversation and engage in some of these questions after they present their work. And the first question, which I say with tremendous respect and deference for the wonderful work that has already been shared on the interprofessional education level at the undergraduate level, is a question about what is the role and the necessity of that educational work during the preclinical years. And because what we're going to hear about are an example during the clinical years at the undergraduate level, and also during the residency training level in the practice setting. So these are both examples in the practice model. And I guess, as George mentioned earlier, there's clearly a tension between what goes on in the academic world and what goes on in our hospital institutions, in our institutional organizations. And I think this question of what is, and in the context of the necessity for efficiency and cost control, I think there's a question that we should really be asking about where's the best place, and is it really necessary that we develop these models at the undergraduate preclinical level, or is the practice level sufficient? And I realize that may be a little bit radical, but something that I hope that we'll think about. The other question is a question about outcomes, and there's been a lot of conversation about outcomes in a group that focused on outcomes earlier. And I'm one of those, I guess, frustrated academics that Malcolm referred to earlier, who is eager to develop the evidence and to really connect this to patient outcomes. There is some literature on this already, and my hope is that we're going to see some great examples here, and that we can have a conversation and take that question about what might be some of the outcomes to the next level, so that we can take our research to a different level and have a greater impact. So with that as an introduction, let me introduce our speakers. The first speaker will be Kathy Rugen, and Dr. Rugen is a nurse consultant to the VHA Centers for Excellence in Primary Care Education. In this position, she is responsible for facilitating transformation of the Centers for Excellence. She is also the Associate Chief Nurse for Education and Research at the Jesse Brown VA Medical Center in Chicago. And our second speaker is Tina Brashears, and Tina is a professor of nursing, the Woodward Clinical Scholar, and attending physician in internal medicine at the University of Virginia. Dr. Brashears is the founder and co-chair of the UVA Interprofessional Education Initiative, which provides leadership and oversight to over 25 interprofessional education experiences for students and faculty at all levels of training. And one of the things that I find so interesting about Tina's background is that she's a internal medicine pulmonary critical care doctor who actually has a joint position in a school of nursing, and I think that's a wonderful model for all of us. So we'll start with Kathy and then go on to Tina.
Thank you, Lisa. Good morning. Pleasure to be here with you today to talk about the VA Centers of Excellence in Primary Care Education. I'd first like to acknowledge our coordinating center, Stuart Gilman, who is our director, Judy Bowen, our physician consultant and my partner. Lori Traylor, who is our wonderful program administrator, and Malcolm Cox, our Chief Academic Officer. So the goal of the Centers of Excellence is to develop and test innovative structural and curricular models that foster transformation of healthcare training from the professional silos to interprofessional team-based education and clinical care delivery. So to give you a little history, an RFP was released in August of 2010. 37 letters of intent were reviewed, 22 were invited to submit full applications, 5 were selected and activated in July of 2011. So we're now in our second academic year. The core requirements for these centers is that there is a physician and nurse practitioner co-director, that there's joint sponsorship and engagement with the academic affiliates, that there's integrated interprofessional teams in the workplace, and that the trainees commit to 30% of their academic clinical training in the Centers of Excellence. Therefore, educational domains in which curricular and evaluation strategies are developed, and I'll give some examples of those a little later. And then the resources for these centers is $1 million per year per center for 5 years for operations. On top of that, there are trainee stipend support, and there's also support for national coordination and evaluation. The 5 funded programs are the Boise VA Medical Center, the Lewis Stokes VA Medical Center in Cleveland, the VA Puget Sound Medical Center in Seattle, the VA Connecticut Healthcare System in West Haven, Connecticut, and the San Francisco VA Medical Center. So this is a schematic of the Centers of Excellence structure and processes. And you can see in the center, there is a patient where learning and caring occurs, and that's considered to be the point of care. Around that point of care are system redesigns that are ongoing. In the Centers of Excellence, we have the educational redesigns, and then throughout the VA system, we're redesigning the delivery of primary care into what the VA refers to as our PACT model, standing for Patient-Aligned Care Teams, which is being implemented nationally. And then outside that, you see the impact that will have on structure and financing at the institutional level, and then the impact on healthcare systems. We call this the eye. Kind of looks like an eye. So for implementation, each program has a different and locally developed training model. There's collaboration across the 5 sites with central coordination. And hopefully that patient care will be at least as good as what's currently happening, if not better. And as depicted in the previous slide, there's program impact at the 3 various levels, at the microsystem or point of care, at the VA facility, and at the academic affiliate, or the mesosystem, and then nationally at the macro system. It's a realistic approach to implementation and evaluation, learning what works for whom in what circumstances and why. Who are our trainees? Well, we have core trainees, and those are physician residents from various disciplines at various levels of their training. Nurse practitioner trainees also at various graduate entries, and also postgraduate entry of the nurse practitioner fellows. We have pharmacy residents and psychology fellows and interns. We have some engagement from social work, from nutrition, BSN students, medical students, podiatry students, and physician assistant students. So a wide variety of students. So this slide illustrates the instructional strategies for learning that should have a balance of developmentally appropriate workplace learning activities for formal instruction that supports the workplace learning, and also for purposeful reflective practice. So the formal instruction is nested or embedded within the interprofessional curriculum that each site has developed. And workplace learning is nested within that workplace of the PACT transformation. And then reflective practice needs to be both inter and intraprofessional, in action and on action, and really needs to be a deliberate part of the instructional design. So here's some examples, and I'm just going to, because of time's sake, go through just a couple of these, and these are just a chosen few and no priority, but of our educational domains, the curricular learning activities, and then some examples of evaluation strategies. So for shared decision making, the curricula focuses on the communication skills necessary to promote patient self-efficacy. So some learning examples are one site used the Ottawa shared decision making curriculum and skills with their trainees. All sites are utilizing motivational interviewing curricula and then OSCEs to follow up with that for evaluation. So one of the evaluation methods is using our VA, longstanding VA learner perception survey, which was recently modified for primary care, specifically for the attributes of the PACT model of patient-centered, team-based interprofessional care. So that new revised learner perception survey was piloted in spring of 2012. And preliminarily, analysis shows that the trainees within these centers of excellence are having higher satisfaction, but further evaluation is forthcoming. Under sustained relationships, the curricula focuses on longitudinal learning relationships. A couple examples are home visits and a curricula based on lost opportunities. We do annual site visits, and at one of the sites, we heard from a physician resident talking about doing a home visit with his NP trainee partner in the home health nurse, and they visited a patient who lived on a boat. And that was such an eye-opening experience for the physician resident, and how he told the story. It was just a great learning experience for him. Certainly in the VA system, we have our wonderful electronic medical record, and one thing we can pull is a continuity of care index, and this is referred to as the modified continuity of care index, which we call MMCI. But that measures the relationship between a provider and a patient based on the number of visits and the number of providers that patient has seen. Also, there's various items on the learner perception survey that look at sustained relationships, not just with the patient, but also with the faculty or mentor. Interprofessional collaboration, the curricula focuses on developing trustful collaborative relationships. Some examples are one site brought in the University of Toronto Center for IPE for some faculty development. Another site has developed huddle coaching program for their faculty and students. All sites are using the team development measure to look at interprofessional collaboration. And probably our least developed curricular or educational domain is in performance improvement. However, in the last several months, we have a cross-site work groups that have started, and they're really looking at the educational needs, and they're doing a cross-site look at ER visits and why are patients going to the ER and not contacting their primary care providers. And examples of evaluation for performance improvement are looking at those clinical outcomes and the QI-CAT, which we heard about yesterday. Certainly our evaluation is largely qualitative in nature. We want to look at what is the impact of participating in one of the centers of excellence on the trainee, the faculty, the staff. You know, what are they learning? How is their performance changing, their satisfaction, the patient experience and satisfaction, the quality of the medical care, the health system changes at the micro, meso, and macro levels, looking at unique and common program factors across the sites and how they affect processes and outcomes, identifying factors that accelerate or impede implementation, and demonstrate also that the appropriated funds were used for their intended purposes. So what are our challenges? Well, not losing sight of that big important piece of staying patient-centered, because you can get lost in all of this. So the most importantly is, are we staying patient-centered? And then next is leveraging these relatively small demonstration projects to change complex systems both within the VA and the academic side. engaging in program transformation while complying with sometimes very rigid research oversight requirements. Advancing interprofessionalism from a good idea to a defined process with behaviors that are measurable. Certainly breaking down those silos and hierarchy, as we've heard from several presenters. Increasing our number of trainees, and that's really limited by space and by the mentors available. Determining the dose. You know, what's the right dose of interprofessional exposure? And also we have a wide variety of trainees that have various levels of need for independent practice or supervision requirements. Certainly we want to increase our associated health training involvement, and that we need to consistently implement assessment strategies in the midst of that academic educational calendar, which certainly varies by locality and by profession. And then defining, achieving, evaluating diffusion of the innovation, or generalizing this across VA and across the nation. So what have we learned in year one? Well, we learned that interprofessional co-leading is hard work. Go figure. So we also learned that protected time for teaching activities remain a challenge, both for the co-directors and for our clinical educators. Co-location of the learners with adequate learning space is essential. We had one site that their room was taken away, and it was a big issue for them and their learners that there wasn't that space for socialization to occur, for learning to occur. The NP learners are, I think, particularly challenged by their academic calendar. We've had some schools that have been very aggressive in making amends to change that calendar and doing some quick educational things up front to prepare the students to come into the clinical environment. But really the NP learners have really the least amount of that longitudinal experience as compared to the rest of the professions, specifically medicine, where we see them staying 1, 2, 3 years in the centers of excellence. So formal instruction is the most well-developed in our sites. Next being the workplace learning activities, and least is that reflective learning. We do have some sites that are using journaling from the beginning. A lot of the NP trainees are in an academic program where that's part of their program is to journal and write reflective papers. So it's happening, but it's not as formalized as it could be. We've heard before, cultural transformation is slow. And we've learned that quality improvement and panel management is a skill that needs to be developed at our faculty level. So we're working on that. And in the VA system, we have a computer program that tracks the provider and associate provider. And only our physician resident trainees are listed as associate providers because of their license. Some of our NP fellows who do become licensed and certified and credentialed in the system do get that status, but that takes a while. So it's hard to track clinical outcomes for other trainees other than our medical physicians. So it's some places have developed some workarounds, but that's something that is across VA. And the one highlight of our program that I'll end with is that in this first year we've learned that the NP residencies or fellowships is the most innovative component. We started in our first year with just one site. Having that, it's a postmaster's 1-year full-time funded program, and now a total of 4 out of the 5 sites have an NP residency or fellowship. The 5th site doesn't have that because they have the Doctorate of Nursing practice at the Seattle VA. So I'll end there and look forward to your questions. Thank you.
While my slides are getting set up here, I just want to say I'm grateful. I guess I'm the last person that gets to say good morning today. It's an incredible honor to share this time with you this morning. I know you're all very busy people, and I hope to make good use of your time. Before I go forward, I have to say very clearly that what I'm about to present is not my work. It's the work of an incredible team. And I want to recognize several individuals individually, Dr. John Owen, Dr. Leslie Blackhall, Dr. Jeannie Erickson, Shannon Thomas, and Lucy Goki have been instrumental in all of this work. And I just want to be very clear about that before we move forward. I also want to say that Deans Fontaine and Dukoski have been instrumental in moving us forward. And I also very much want to thank the Josiah Macy Jr. Foundation, without whose support we would be nowhere close to where we are today. What I'd like to describe to you is a 5-step model that we are now using to advance team-based education and collaborative practice at the University of Virginia. That model is based on developing, I love the terminology, it was pithy, relevant, and measurable interprofessional education. I wrote that down yesterday. We really want clinically relevant interprofessional education that is required and fully integrated across the learning continuum, that is assessed longitudinally, that is associated with a commitment to rigorous research and dissemination of results, and seeks to bridge the gap between education, patient care, and patient outcomes. We have developed something we call the Collaborative Care Best Practices Models to support our creation of our interprofessional education experiences. These models are based in clinical guidelines that address areas of need in our health system for improved teamwork. Expert panels, interprofessional panels, choose the guidelines and develop cases and checklists of behaviors that are essential for adequate implementation of those guidelines. Those checklists of behaviors fully integrate both the profession-specific and the interprofessional skills for optimal guideline implementation. From these collaborative care best practices models, we can create not only clinically relevant interprofessional experiences, but also assessment opportunities. We call these collaborative behaviors observational assessment tools, and we use these to assess students during interprofessional teamwork OSCEs. By creating tools and experiences with this method, we can use the same process to adapt tools appropriately for the target learner. A simpler model for our undergraduate students, a more complex model for our residents and graduate nursing students, and I would call a gold standard model for our fellows, clinicians, and faculty. This process also embeds IPE in a very clinical base in the sense that we believe that the skills that are important for interprofessional collaboration around a crashing sepsis patient are somewhat different from the skills necessary for appropriate interprofessional collaboration around an end-of-life discussion with a family member. So we have an opportunity to develop interprofessional experiences and assessment tools that address specific patient populations, illness experiences, and care settings. This also gives us very specific and measurable learning objectives that we can work with. It integrates profession-specific with interprofessional so that our students don't see a divide between what they need to know and how they need to deliver that care. And it establishes IPE as very much core to their clinicals and clerkship experiences. This is just a quick, colorful view of what the Josiah Macy Jr. Foundation has done for us using this model in 4 important care areas, patient populations, and care settings. Because of our funding, all of these are geared at our undergraduates, specifically third-year medical and nursing students rotating through clerkships and clinicals, but we've already developed several other opportunities for our students at different learning levels and are now focusing on graduate medical and nurse practitioner education. So as I think you can see, these address various illness experiences, care settings, acuities, etc., and we match them with our IP competencies. I just wanted to give you a little bit more of a micro view of one of the ones that pioneered this work. This work was done by Drs. Littlewood, Tolman, and Wright. We do a little bit of an orientation to teams, but it's done in a PBL model. And then we move very quickly to a very hands-on, high-fidelity simulation in which the profession-specific skills associated with the surviving sepsis guidelines are integrated fully with interprofessional skills for how to implement those guidelines. Students make the learning objectives their own by being equipped with the behaviors checklists which they use to assess themselves and assess each other as they go through the simulation. Then we do debriefing and they do reflective learning after the simulation in the form of their student learning portfolios, clinical logs, and qualitative portions of their evaluation tools. The second major component of how we view interprofessional education at the University of Virginia is that it has to start early and it has to continue through the learning continuum. I realize this is too small to read, but this is our curricular map that equips us with several important things that we can do. We can see how best to match students. In some situations, for certain tasks, it might be a fourth-year nursing student with a second-year medical student, or it might be a third-year nursing student with a first-year medical student, or sometimes the reverse. There are settings in which the nursing students are far ahead of the medical students, depending on the task, and we can match them appropriately. That's also occurring at the graduate level, although I must say we have a long history of educating our nurse practitioners and our medical and surgical residents together. We do not have as intentional, as coordinated approach to interprofessional education at the graduate level, and that's one of the places where we really want to focus. Another thing that this allows us to do is to match our curricular map with our competency map so that we can really see how students, or make sure that they address all of our competencies and do those in a logical fashion. We also then can move very quickly into educating students, clinicians, and faculty on some of the same skills, but sometimes together. And we found that that's actually effective. As long as we don't have to do too much assessment of one another in front of one another, it is possible for students and clinicians and faculty to learn together. Faculty development is a very important part of what we do. The picture that you see here is when we had 37 people spend 3 days over Martin Luther King holiday with the Toronto EPIC group. We have a number of other faculty development opportunities. Certainly want to recognize Brenda Zierler and Les Hall's work with the Macy Foundation Faculty Development that many of my colleagues and I are participating in. And I also want to recognize our consultants. I can't tell you how much a consultant can mean. When an outside person who's well recognized and well respected comes into a setting and says that this is something important, it can be transformative. And I must say we were in a win-win situation from the beginning. How could we lose when Maddie Schmidt was our first consultant and our most recent consultant was Scott Reeves? You just can't go wrong. Our chief medical officer attended Dr. Schmidt's medical center hour, which is open to the entire health system and schools community, and after hearing her talk, came to her and to me and said, how can we integrate interprofessional values into our values model for our health system? So this can be transformative and something that I really wanted to share with you. The third step in our model is longitudinal assessment of IPE competency. Certainly every experience we have evaluations associated with that. We have reflective opportunities for students. But in order to really make sure we're doing what we say we're doing, we do pre and post testing of our third-year students prior to their clinical clerkships, which contain these IPE experiences, some of which I've described to you. And then we do post-testing using these collaborative behaviors observational assessment tools and Daitowskis that we've developed based on collaborative care best practice models. We have done the pre-testing now. We're currently just finished with year one. We've done all the pre-testing, and our first post-testing will occur within the next couple of months. We also do some longitudinal assessment of our continuing interprofessional education, although that is much more challenging. We are exploring the commitment to change model, which in the literature has been shown to actually change practice for some individuals who participate in continuing interprofessional education. They fill out their commitment to change before they leave the activity, and then we follow up with them at 3 and 6 months. So we're looking forward to being able to report the results of that to you soon. We really love research in our group, and this is a huge strength for us. By participating in funded research for almost everything that we do, it really raises the quality bar for us. Our methodology has to be clear, our rationales have to be clear, Our outcomes measurements have to be well defined. We think this really improves the quality of what we do. Also, by using funding, that certainly incentivizes other faculty and clinicians to become involved. It allows us to respond to nationally identified areas of need for innovation. And when we come to the table, when there are other grants that are going on in the schools or the health system, we come as full partners instead of asking if we can join them. We say, look, this is how we can make your grant that much more successful. The fifth step is bridging the gap between interprofessional education and patient care outcomes, and I'm grinning a little bit just because this is the challenge, this is what we're here to talk about, and I don't want for a minute to suggest that we have this one down. We're just really beginning here. Our funding was focused on third-year students, but we're moving forward, and again, thanks to the Macy Foundation, one of the steps that we're taking for moving interprofessional education from the classroom to the sim center to the bedside to teams to patient outcomes starts with something we're calling the UVA Health System Collaborative Care Projects. This is an award program that incentivizes healthcare teams in the hospital to develop new models of interprofessional care and to include students at various learning levels in their activities. Part of the criteria for them winning these awards is the measurement of at least provider outcomes, clinical provider outcomes, and optimally special recognition given if they're also able to measure patient outcomes. As we look to the future, we are about to launch our UVA website. This seems like a small thing, but I think many of you who are in academics realize how powerful a tool this can be as well. We hope to build in a lot of resources, although with the Med Portal being also such a great resource, we certainly don't plan to duplicate all of that. We want to make it a bit more institutional specific so that people know who to go to when they have an idea and want to learn how to implement it. We've just learned that we are getting endowed funding to partially support an academic strategic partnership for interprofessional research and education. Acronyms are big in this business. It's going to be called the UVA Aspire program, which will help us sustain our programs into the future. And we have a lot of grant proposals that we're developing, too many to count actually, but I wanted briefly to mention one relevant to this group, which is the UVA Health System was just funded by a large CMS grant to develop a unique database in which not only providers but patients directly input their clinical data into this database. And I think it might get to some of that functionality issue that we talked about earlier. I suspect what patients will put in there is different from the information that we get from traditional provider input. They'll also be creating some interprofessional teams that will have a new way of approaching patients in the cancer center and are already expressed an interest in working with us to include students at both the undergraduate and graduate level in their work. So to summarize, I'd just like to say that the University Interprofessional Education Initiative has been very successful in some ways because of the tremendous support that we've received, that it's based on clinically relevant work that's rigorously assessed, a commitment to research, and really wants to move forward to bridge this gap. And we look forward to any advice that you all might have to move our efforts forward. Thank you very much.
So much, Kathy and Tina. So I want to just ask each of you first to comment before we open it up for questions on the first question that I raised earlier about the necessity of interprofessional education prior to the clinical experience. And in particular, I guess, Kathy, given your work with residents that are coming from multiple educational experiences at the undergraduate level, some of whom may have had interprofessional educational experiences and some of whom may not have. You're actually, I think, uniquely situated to actually study, but potentially stratify and study the impact of people that have different backgrounds and look at what are the different outcomes there and help us understand maybe if we can focus only on, should be focusing on the practice level, or should we also be thinking about this more throughout the entire educational experience?
Thanks, Lisa. Just to comment, I don't think we're collecting that information on our trainees. Is what have they had prior to coming into the clinical setting, which we need to do. Now we are doing a whole bunch of baseline measurements, both qualitative and quantitative, with the trainees throughout from the baseline to the end of their program. So that it might be good to then match if they come in at a higher level, if they've had these prior IPE experiences. But we need to start collecting that.
I think that's an excellent question. I think that it's a question that's not unique to interprofessional education. I mean, I don't know how many of you took biochemistry, and am unsure to this day how much that actually informed my clinical practice. The ones that I remember are in the clinical setting. And so I certainly think that, you know, perhaps some baseline understanding of the principles is key. But we certainly believe that where students gain the most knowledge, even at the pre-graduate level, at the undergraduate levels, in the clinical setting. But those are measurements that need to be made.
Oh, just a comment is that so when we do our site visits, we talk alone with the trainees, and you know, I'm really stunned by how much they appreciate the time that's spent learning who their colleagues are. And they really comment about, you know, gosh, I never knew what it took to be a pharmacist. I never knew what it took to be a psychologist or a nurse practitioner, etc. So that leads me to believe that maybe there wasn't a whole lot, or it diluted over time and didn't come with them to the clinical setting.
Good, and I think one of the interesting questions moving forward will be also what is the cost associated with developing those kinds of programs from the get-go, and is there a significant impact above and beyond what we can achieve by creating these interventions at the practice level? And I guess we'll have to wait for future research before we can answer those kinds of questions. I'm also just wondering, before we open it up for questions, if you could each comment on this issue of outcomes a little bit more, and maybe if we can take that question to a different level. There certainly has been some research in this area. Colleagues of mine at the Brigham did some work that was published in the New England Journal about 2 years ago, looking at an integrated team-based approach, which actually did show some differences in both mortality, which the New England Journal found to be somewhat controversial, and so it's not highlighted in the article. The study wasn't powered to look at mortality. There were also other differences in terms of length of stay that have significant implications in terms of cost. So I think that there are some patient-related outcomes that we should be thinking about: readmissions rates, adverse event rates, and I'm curious to hear both if you, in your own programs and research that you're doing, are thinking about these things, and what might be some of those patient outcomes that we should be really closely looking at.
Well, from the beginning, at the onset of these programs, they had each site had to write a proposal as to what chronic health measures they would be evaluating, what preventative indicators would they be evaluating. So they're looking at the standard chronic ones of hypertension control, diabetes control, weight management, smoking cessation. So they built that into their program to look at those clinical outcomes. So that's part of the panel management. Again, the issue with tracking, only the physician resident is an issue with the other tracking outcomes for the other trainees. In addition, I lost what, I'll come back to it.
I don't really have a lot to add to that, other than I think a sustainability issue is that we continue to address those patient problems that are considered the most critical by insurance companies, by Medicare. I just think that if we start looking at things that they're most interested in and then build out from that we're more likely to be supported in the work that we do.
Yeah, and just the other one was that I mentioned in my presentation was all the sites are looking at the ER visits and why are these people going to the ER, and a lot of them are for medication refills. So it's, I mean, at the basic level of patient education is, pick up the phone and call and we can take care of it for you. Call your pharmacist.
Wonderful. So let's open it up to questions. Jordan.
Well, I just, first of all, thank you both very much. These are really robust and very, very impressive programs and accomplishments. So I congratulate both of you. But I just wanted to make sort of an obvious observation, and that is that this kind of robust activity and the success you've had, I think, illustrates the importance of leadership. First of all, institutional commitment to allow you to do these things, from the kind of resources and the encouragement and all the other things that the culture of your institutions has provided, but also illustrates that leadership isn't just at the top, but it's leadership throughout your organization. You two are examples, but I'm sure in your teams you've got other examples of people who are taking initiative, who are pushing the agenda forward. So again, it ratifies, I think, what we've said several times during this workshop, that the culture of the institution, the commitment of leaders at all levels of the institution to make these innovative changes, I think is crucial if we're going to get any kind of pace and magnitude and scope of these kinds of activities. So I think it's just a marvelous example of what we have seen and talked about in theory.
If I can just respond to that very quickly, is to say one of the reasons that we launched is we got 2 new deans at the same time. And so they had to learn how to work together on all of their levels, which I think provided some insight into helping the 2 schools integrate.
George?
So first of all, congratulations on 2 great presentations that really begin to answer the kind of proof of concept question of can you do it? I want to respond to Lisa's challenge, and then I want to ask Catherine a question. The issue about the evidence that getting it early makes a difference is not there, but it's based on a premise. You know, some of the work that we're supporting is based on a premise that we have a lot of data that stereotypes actually exist on arrival into school and then are reinforced over and over again. And on the premise is that if you wait 4 years before you introduce the idea that you're a member of a team and begin to develop those skills, it may be too late. And the present dysfunctionality of our healthcare system is one evidence of that. So we need proof, but there is a plausible hypothesis that starting early does make a difference, but we need to measure that. I want to ask Catherine, I know it's early. You're less than 1.5 years into operation. Do you have any inkling yet that you're having any crossover or contaminating effect on your affiliates in the ivory tower?
Oh, yes, we get phone calls almost daily from both the medicine and nursing side, looking at what we're doing and you know, how they can learn from what's going on. We've been charged with the Office of Primary Care to write a white paper about how do you run an academic PACT, because PACT was developed not with a trainee in mind. So a white paper is being written. Judy Bowen and Gordon Scheckman are heading that up, and that's soon to come out, because we have to spread this. And I think that at the sites where this is occurring, there is some contamination and crossover, because some of the faculty precept and have their patient care in other clinics rather than just solely in these centers of excellence. So I think we do see the bleed.
Could I just add
Please.
to that? Because I think it's a critically important question. They're both positive and negative effects. And that is at one side, I'm sorry. It's on, it's red, but my voice is sinking. We're all tired. They're both positive and negative transference effects that George is trying to get at. I mean, I think most of them are positive, as Kathy said, interested in things, but some are bothered about the intense interest that some of the training programs or the applicants for training programs have in doing this kind of integrated approach as their ambulatory care experience as opposed to traditional. And I just use, that as an example. So I think it behooves us to be aware of both good and bad, because we have to manage both.
Darla, and then Patricia in the back.
Thank you. All of the examples shared this morning have just been truly inspiring, so thank you. I wanted to make a comment and ask if you could just reflect on it, because one of the things that I've heard this morning and yesterday is that an important part of an interprofessional curriculum is about creating space. So when we build curriculum, we often think about how to fill the space, what needs to go into the program. And what I've heard is the importance and maybe needing to pay attention to assessing how the value of the space that's created. Two spaces I heard. One is the social space. The students reminded us yesterday that lots of learning goes on outside of the classroom. The learning from each other, the time to do that. I think that sounds really important. The students got upset when the room was removed, you know, the space, physical space to have that kind of social activity and interaction. And the other was the space to reflect. We've heard that a few times, and I'm not sure that we're thinking about how to assess the value of that as well. And if you could just comment on those. Oops.
That is about as well stated as I've ever heard that question. Thank you. I think it's a really important one. I think that students often aren't comfortable with a lot of formal space. We found with a lot of our interprofessional activities that they get best evaluated when they're almost frenetic. And I think that, you know, we need in many ways a culture change. I think the students feel they're, quote, wasting time when they're not really actively engaged in clinical care. Where we're addressing that, and I say we very broadly, particularly Doctors Blackhall and Erickson, is in the end-of-life work, where that's really one of our strongest interprofessional activities at all different learning levels. And you really can't engage in those simulations and discussions about that without creating some space for students to think about their own lives and their own perspectives on that. In terms of social space, if I could say one more thing, I'm not sure if you're familiar with the University of Virginia, but we are very admiring of Thomas Jefferson as the founder of our institution. And one of the ways we've created, or I'm working with two students right now, one medical student and one nursing student, to create a social space and yet make it not just about what happened on Facebook yesterday, is we're making it an honorific opportunity for students to attend what we're calling a Jeffersonian dinner, which is something that's allowed for faculty, but has not been done at the student level, to invite students who've demonstrated particular interest to come and sit down in small groups. It's a group of 12. To talk about both formal and informal ideas about how to work together and make that something that they really want to participate in. So that's one small solution that we're trying to address, but I thank you for that question. It's an important one.
Yeah, and space is a big issue, and it's an institutional issue to make more space. And you know, the learning needs to take place even if patients are on one corridor and they're being seen by students in that corridor, and they have no appreciation for what's happening down on the other corridor. You lose that workplace learning, and if they're not in the same area precepting, it's just back in our silo. So so we really need that co-location and not just sitting in the same room together and listening to a lecture. It has to be an environment where they can have some dialogue and socialize.
Kathy, can I just ask you to follow up a little bit on that in terms of, you talked about the nurse practitioners in your program doing some journaling. I'm really curious, I guess, what you do with your residents, because it strikes me that that's such a hard area to find that space for reflective practice. Are the residents also journaling? What's going, and what's their response to it?
At two sites, they have been since the beginning. I think it was what we've heard is a little bit hard, a rocky road up front, but I think it's, you know, it's not for everyone. I think there's certain individuals who really get something out of it, but for the nursing, definitely that was part of their curriculum. But two sites really have had some good success with the residents journaling.
Great. So there was a question in the back, Patricia, and then FF and Patty.
Thank you for two great presentations. One of the things I've been struck with both yesterday and today, and just a comment and thinking about actionable items. We've talked about making sure that models are disseminated, but I'm just really struck with the number of assessment instruments. You know, we've been talking about measurements, but not just with your presentations, but with others. And I think we, in the health sciences community, tend to think we have to recreate the wheel for our institution. And I'm wondering if maybe we could think about a resource tools of not just today, but others that have been shared. But my real question is whether or not you're looking at reliability and validity of some of these instruments so that we could begin, and again, I think that's where multi-institutional opportunities, because sometimes it's an N factor that makes a difference. So I'm curious about where you are with reliability and validity of the instruments and how we could think about circulating those for building on our assessment and evaluation of outcomes.
Excellent question. And we have put more time than we ever dreamed into the validity and inter-rater reliability of our assessment tools. So much so that despite generous funding from the Macy Foundation, we've had to get two other external or internal grants, but two other grants to really work on that. We use a whole series of videotaping and going back through these over and over again until we achieve what we believe to be very high levels for what is really social type of tools. These are not the same kinds of tools in the social sciences. What's considered an adequate cap or percent agreement is a little bit different from what it might be in some other areas, but we're looking at 70 to 80%, often 90% agreement across our tools, but it's very labor intensive. So when we're now sort of maturing in terms of what we can export for models, what we're really looking at is probably exporting a case and the tool together so that you really can take advantage of the work that we've done that not every institution would be able to do for themselves in terms of time and resources.
And when we looked at the quantitative measures, such as like the dyadic option or the decision support tool, a lot of that work has been done with only physician trainees, not with nursing. And we scoured the nursing literature for some valid and reliable tools and didn't find many of them. And we're like, well, do we just use what's here, or, I mean, are we going to create something new? Specifically, the QI cap, that is for medical residents, and we've changed some of the scenarios because they're really not applicable to the role of a nurse practitioner. Yeah, it was difficult. I mean, and that's just those two professions, let alone the many
And so
others.
I'm really wondering, when we've had all of the comments, every one of them had funding as a part of what came out of the small groups. And I think maybe we need to be clear, it's not just funding related to IPE itself, but funding related to the instrumentation that really is going to help us with that next step, because I think we haven't been that specific, and it does take a lot of money. Thanks.
Just a comment about space. It's not only students who need space or faculty, it's really the clinicians need space also in terms of clinical judgment. So, but nobody pays for space. That's the problem. Exactly. So thank you so much for your presentations. You are modeling collaborative leadership, I think, by actually being collaborative in your leadership. So I think it would be wonderful to write a paper on what collaborative leadership and how is it reinforced and some of the obstacles in it. I think this would be great for everybody. I want to comment on to Catherine about there is a great program in the VA related to palliative care, and it is national. And it is organically, it's interprofessional. So it's not that interprofessional is imposed on it. And I think it would be really nice to look at that and evaluate it in terms of the effect of that on actually delivering palliative care and some of the outcomes, because it's there already. You don't have to create it, and the data is there.
Great, thank you. I'm familiar with that program, the LNEC, the End of Life, and I know all about that in my other role as the Associate Chief Nurse for Education and Research, but very interesting. Thank you. I'll bring that to the center's attention. Thanks.
Great. Maddie?
Tina, I think one of the unique things about your program that we have had very little discussion of here is the continuum of IP learning and the way that you have integrated continuing education into the work that you're doing. And I'm wondering if you could just share a little bit more about that.
I think everyone probably has this problem, so I don't think I'm making a true confession, but we lacked for trained facilitators. We have a large number of interested people, and as we talked about in our smaller group yesterday, if you show the IPEC competencies to any of our faculty and clinician colleagues, they all believe they are already really good at those things. And they also don't recognize that how different it is to educate students in teams like this. We have team-based learning in the medical school now as part of what they call the next generation curriculum, but it is still unidisciplinary. And so it was pretty easy to pick up that even the interested people in what we were doing were really not that well prepared. And I include my direct colleagues and myself as well. I mean, I had a lot of scholarship in the area, but there's so much more to learn. So when we realize that what we need to learn is the same at this point, it's almost a unique opportunity because we don't have people walking around saying they're the experts. And that there's only one way to learn or to do these things. So what is a challenge is also an opportunity. And so by creating this model where it's really all about delivering the care, and the model we chose is clinical guidelines, you could choose another model, we really have the tools necessary to educate across the learning continuum without having to reinvent all of these tools over and over again. We simply apply them appropriately to the learner. So I gave you the example of the third year surviving sepsis guideline that we used for this simulation. The expert panels that developed the list of behaviors for that and all of our other sessions were like, wow, we've never sat down and talked about what does it really take together to deliver this optimally. And it was an amazing faculty clinician development opportunity, thinking they were doing it for students, and really they were learning a lot of it themselves. The fact that so many people participated in a 3-day-long session, I don't really recommend that as the primary tool for educating across the continuum, because we really felt like we spent a lot of our capital getting people to do that. But we now have a speaker series that students and residents and nurse practitioner, graduate students and faculty and clinicians can all come to, where even if the topic isn't interprofessional, they've opened the door and said we can introduce an interprofessional component into all of these topics. So, you know, we don't have students. I love what Missouri is trying to do in terms of actually having students who've made a commitment to stay as residents, to be able to truly do longitudinal. I think that's something we will look at. We do have a lot of residents who stay, but to be able to just measure across the learning continuum, I think is very important to us.
Unfortunately, I'm sorry. I know that there are a lot of other questions, and I apologize that we'll have to stop here given that we're out of time. I just want to thank Tina and Kathy for sharing with us their tremendous examples of rigorous research and really leading the way in innovation in this area.
To meet you too. Fantastic. I think of a couple of things, and one is that as an association of educators and institutions, I'm going to leave here going home telling the early adopters and the ones right behind them that they are so not alone, that there is so much to access, to implement, to learn from, learn with including next Tuesday from 12:30 to 1:30 Central Time, when Brenda and Les Hall will be having a webinar sponsored by the AIHC. And that information is up on what to be able to link to it on the AIHC website. Tremendous. And I have thought at least about 6 times in the last day and a half about a major omission I have made. This all has looked really easy to pull off, right? That this meeting came together, you know, without effort, flawlessly, etc. Well, that is not the case. I acknowledge my planning committee, our planning committee at the beginning, but this really works because of the IOM staff. And Patricia, Megan, Rachel, the tremendous audiovisual team that has been working throughout feverishly to link us to Australia and Africa and lots of other points in between. So I really am remiss in not having said that. And I will now invite Harrison to come and introduce our final keynote speaker. And then the person who I envy the least is Martha, who is going to summarize all of this before we depart or have lunch at 1 o'clock. Thank you.